1 million cases of new or repeated strokes annually. And a stroke is just when an area of the brain is deprived of circulation. So when it doesn't have circulation, it doesn't have proper oxygen or glucose levels, which we know the brain does not like at all. Right, so there are two main mechanisms of stroke, and those are going to be ischemic and hemorrhagic. Now, ischemic stroke is when a blood clot actually blocks arterial blood flow to a portion of the brain. These are most commonly from a thrombus formation, but can also occur from an embolus. Hemorrhagic, on the other hand, occurs when there's a rupture of that blood vessel within the cranium. And this intracerebral hemorrhage occurs when there's usually an aneurysm or arteriovenous malformation ruptures, baryaneurysm, something has ruptured there. And whereas a subarachnoid hemorrhage occurs when a weakened blood vessel bleeds into that subarachnoid space between the brain and the arachnoid layers of the meninges. It's important terminology to know with your strokes. You've got aphasia, which is difficulty or loss of language. Now, this can be expressive or receptive, so either saying or interpreting. And it also includes both spoken and written language. So some people may be able to speak but not write things properly. Like they may intend to write blue and they write duck. It just depends on how it presents there. Ataxia is a lack of coordination. I seem to suffer from this myself on a daily basis, but in the setting of a stroke, it is one of the indicators there. Dysarthria is difficulty speaking due to motor function. So it's not that they don't know the words or the words are getting mixed up. It's the muscles that allow us to speak either in the face, the jaw, the tongue, are either weakened or paralyzed, so they can't physically get the words out. And a lot of times this will result in actual slurring of the speech pretty significantly. All right, hemenopsia is where you're going to have a loss of half of the visual field, usually, opposite side of what's affected there. Hemiparesis is going to be weakness on one side of the body, and then hemiplegia is going to be paralysis on the one side of the body. Now, when we're looking at your ischemic strokes, it's often the result of atherosclerosis of the cerebral arteries or of the internal carotid arteries that supply the blood to the brain. The risk factors for this atherosclerosis are the same as those for cardiovascular disease. Now, when a blood clot or plaque that's formed in the internal carotids breaks loose, it can form an embolism that then travels to the brain circulation until it reaches a point where it can no longer move and it becomes lodged and obstructs the blood flow. Some of your kind of leading things that can lead to that are going to be your cardiac dysrhythmias, like AFib, can lead to formation of blood clots that can be then sent into systemic circulation. Now, your hemorrhagic strokes are going to occur from the rupture, like we said, of the aneurysm or from AVM. And that's just your abnormal connection between your arterial and venous circulation in the brain. For that, your hypertension and atherosclerosis are also risk factors for your hemorrhagic stroke. But patients may also have some kind of congenital abnormality there that kind of lends to that hemorrhage, okay? Now, we know the brain absolutely requires oxygen and glucose all the time. So this means that any kind of dysfunction in these affected areas is going to have an effect immediately. And so neurological damage and death can actually start to occur within about 4 minutes. Depending on the artery affected, there can be collateral circulation that may provide some perfusion to that affected area, which is going to maybe increase the amount of time before irreversible damage is done. If perfusion is restored, the injury can be reduced or even reversed. These initial signs and symptoms are going to reflect the area of the brain that's deprived of the stroke. All right, in a severe stroke, these initial signs and symptoms are going to reflect the area of the brain that's deprived of perfusion. And in a severe stroke, the secondary brain injury and edema can lead to even worsening signs and symptoms and progress to altered mental status and even impaired breathing. So some of our more common warning signs are going to be like sudden numbness of the weakness of the face, the arm, the leg, especially if it's on one side of the body. Sudden confusion or difficulty speaking or understanding. Sudden difficulty with vision in one or both eyes. Sudden loss of coordination, difficulty walking, dizziness, sudden severe headache with no other known explanation. Some other things may include inappropriate display of emotions, particularly laughing or crying, or inability to control those emotions. There's some differences between your left and your right side CVAs, how they may present. Now, it's important to note some differences. There are some differences between the onset of your ischemic and your hemorrhagic strokes. Often, your hemorrhagic strokes are going to begin with a sudden onset of severe headache, unlike any other headache they've ever experienced. And this is going to follow with progressively worsening signs and symptoms. Right? The brain itself does not have any pain receptors, meaning that the ischemic stroke is not initially painful. But the meninges do have your pain sensors. So when you have blood in the cranial vault, it's irritating to the meninges, which we perceive as pain. And depending on the speed and the amount of bleeding, mental status may decrease rapidly and ICP can go up significantly. In ischemic stroke, there's often no headache, and signs and symptoms are at their worst at or near the time of onset. Patients can also present with signs and symptoms of a stroke that can resolve itself within a couple of hours without cerebral infarction, and this is called a TIA, or transient ischemic attack. In this, there's a temporary interruption in perfusion, usually from some kind of atherosclerotic disease or emboli here. And your signs and symptoms may even sometimes last up to 24 hours, but we never want to take the kind of wait and see approach, because ultimately, whether they say it's a TIA or a stroke just is whether or not the damage is permanent or not. So we don't want to take that risk that it is permanent. We'd rather transport them and have them evaluated. So our treatment. There is a stroke chain of survival, much like the chain of survival for cardiac arrest. But one of the weakest links in this chain is bystanders' ability to recognize the signs and symptoms of a stroke. Okay, so this may lead to a delay in seeking of care. So public education is really pushing big to try to recognize this. So early recognition of the symptoms, all right, immediately requesting EMS, high priority EMS dispatch classification for stroke symptoms, transport without delay to the most appropriate stroke care hospital with early notification of the receiving hospital, prompt evaluation and care at the hospital, implementation of care decisions for medications and interventions, and admission for a stroke or intensive care unit or transfer for further care. So that's all what's included there in that chain of survival. So the EMS role in this is to recognize the possibility of a stroke, provide immediate treatment, and transport without delay to the most appropriate facility. All right, we want to use a pre-hospital stroke screening tool to identify the potential stroke patients. We want to support their ABCs. We want to give oxygen to maintain an SpO2 greater than 94%. We want to manage any hypotension. All right, if they have a systolic blood pressure of less than 90, they may need to have a little bit of oxygenation. All right, we want to make sure that we establish the onset of signs or symptoms of the last time that they were seen normal. We want to select an appropriate receiving facility, transport without delay, start IVs en route to the hospital as per protocols. Be prepared to manage your seizures, notify your receiving facility. Make sure you check a blood glucose. Sometimes hypoglycemia can present very similarly to a stroke, so check a blood sugar. But if you listen to any of my other stuff, you know if you have a patient with any altered mental status whatsoever, you check a blood sugar. You also, depending on where you are, you may also have some kind of initial screening tool similar to your pre-hospital stroke screening to determine eligibility for fibrolytics. So with all of our patients, we start with the ABCs, right? The primary assessment. We know that our patients with a stroke are at a higher risk for upper airway obstructions due to inaspiration, vomiting, impaired swallowing, things like that. Okay, so we're going to use positioning. We're going to use manual maneuvers, and suction is needed to open that airway and manage their secretions, help them manage their secretions. If their level of consciousness or responsiveness is impaired, we may use basic or more definitive airway adjuncts as indicated. If their ventilations are inadequate, we're going to use BVM. We're going to maintain that, treat any hypoxia to maintain greater than 94%, 95 or higher SpO2. If they do not have hypoxia, though, we're not going to just willy-nilly give them some oxygen, only if they need it. All right, an elevated partial pressure of oxygen can cause vasoconstriction, which could impair perfusion to the brain. Now, patients with a stroke may be hypertensive, but it's not currently recommended that we treat this high blood pressure in the pre-hospital setting, because if we lower that mean arterial pressure, it could lower the cerebral perfusion pressure. So if that cerebral perfusion pressure drops too much, that ischemic brain may not be perfused adequately. So really important there. If they're hypotensive, systolic blood pressure of less than 90, They're also at a risk of inadequate perfusion, cerebral perfusion, so follow your protocols or consult with your online medical direction determining IV fluid administration in your stroke patients. Now, once you have managed his airway, breathing, circulation, onset signs and symptoms, okay, as exact as possible. If they woke from sleep or a nap or something like that and we don't know when it started, find when they were last seen normal. If they're a candidate for this fibrinolytics, typically it should be initiated within 3 to 4.5 hours. Now, there are some places who are pushing that out further, but the standard as of right now is within about 3 to 4.5 hours. The more quickly it's administered, the less cell death that you have. It's estimated for every minute without perfusion, about a pea-sized portion of the brain tissue dies, which is approximately 1.9 million neurons and 14 billion synapses. So, there goes years 3 and 4 right there. There goes kindergarten. I personally try to transport somebody with me that's knowledgeable about this patient, not just in strokes, but in any time that the patient is unresponsive and unable to give me information or permission or sign stuff. I always try to transport somebody who is capable of doing that, who can give me that information that we may need or the hospital may need with us, if at all possible. All right, some things you want to think about for fibrinolytics, some general inclusion criteria, and this varies based on where you are, but your ischemic stroke, with measurable neurological deficit. So in other words, you have to have some kind of deficit. All right, onset of symptoms less than 3 hours, and they have to be 18 years or older. Now, exclusion criteria, why they would not be candidates for this. History of recent significant trauma, surgery, arterial puncture, or GI bleeds. Active hemorrhage. Suspected or known cerebral or intracranial bleeding. A previous cerebral hemorrhage. Intracerebral tumor, aneurysm, or AVM. Disorder that causes delayed blood clotting or anticoagulant drugs. Low platelet counts, hypertension that's uncontrolled with meds, pregnancy, and minor or rapidly improving symptoms. So, they kind of make sense if you think about them.